Good afternoon, and thank you for joining us today. My name is Diane Dome. I am one of the nursing home project specialists here at MetaStar, which is part of the Lake Superior Quality Innovation Network. Today we have an exciting program featuring 3 Wisconsin nursing homes talking about what they have done to reduce nursing assistant turnover. And we are switching our slide order up just a bit due to some technical difficulties. So our first speakers will be Sue Hicklin and Tracy Rather from a Grace Hospice Care based here in Madison. Following that will be Ryan Hansen from Pinecrest Nursing Home of Lincoln County. And closing the presentation for us will be Laurie Carroll from Wisconsin Veterans Home in Union Grove. Please enter your questions into the chat box and they will be addressed by our speakers at the end of the presentation. And now I will turn it over to Sue and Tracy.
Good afternoon. I'm speaking to you from a Grace Hospice where we provide care to about 900 patients in south central Wisconsin and northern Illinois. We partner with many facilities in those geographies as we provide care to people on hospice services. Here to talk a little bit about our CNA recruitment, because just as all of you need CNAs in order to provide care to your patients, that's our situation as well. We've adopted a management philosophy to support the importance of CNAs as part of our interdisciplinary teams caring for patients. It's very important that the CNAs know how much we respect their hard work. We do that by our HR staff actually very frequently going out to the market and identifying what the current wage rates are being paid to CNAs so that our CNAs are well compensated for the work that they do. We also have found that our CNAs are very autonomous in the work that they do, may be the only person in a patient's home at the time that they're providing direct care services, and or be independent working alongside your team members as they provide care to patients in facilities. The most important thing that we can do is ensure the CNAs know that we trust them to do their jobs. When we are working in homes and or in facilities where their supervisors are not directly present, we have to make sure that we understand what their challenges are and provide them the education and coaching to be able to do what's asked of them. So the CNAs know that not only are their managers, nurses, and other members of their team available to them by phone, but also they can come into the office and our clinical education staff is well prepared to provide them any education needed based on a patient's individualized care needs. As we go through our work together, we have regular situations where we discuss how things are going for the CNAs. And recently, we had gone through a project where we tried to increase the efficiency of how the different CNAs were scheduled across their geographies so that they could spend more time with patients rather than driving in between their patients. And in doing that, we discovered that many of our CNAs, especially on the day shift, were not getting lunch. And that's because that's a very busy time of day, as all of you know, where they would be providing dining assistance to our patients as well as finishing up with any showers or other cares that they were providing. So semester by semester on their schedules. As far as engagement, we have been working very hard with our frontline staff as well as all of our team members to make sure that our staff is involved as directly as possible in patient care. And that goes for our CNAs as well. We have interdisciplinary team meetings where we review their plan of care, and the CNAs are a part of that. So often they will see our patients more often than other members of the team. So the changes that they see and how we're able to respond to that has been very important as we evaluate how the patients are doing and how well we're meeting their goals. And then lastly, our project teams, we've become involved in a lean initiative, and the most important input we get is by those providing direct care to the patients in what we can do to improve that. Knowing that our CNAs are spread out, though, over 22 counties, if you count both of the states that we're providing services in, whenever possible, we use Skype as a way to connect our staff to meetings so that we reduce their drive time, but we're still able to get their input. And so with that, Sue will share her experience as a member of our team.
Hello, my name is Sue. I'm a CNA with a Grace. For me, one of the big things that I've always enjoyed is hearing about a Grace in the community and knowing its reputation. It made me want to be part of that community. It's very, hard to get a position with a Grace. A lot of people wanting to get in and a lot of applicants. It's a involved process for hiring. They take that very serious. They invest a lot in that process. There's usually 3 people that I sat with, and they cover different areas of the CTM. There's HR and CTM being the team manager. They ask a variety of questions. They make you really think about your answers in a way that you can see them also doing the same. They care deeply about who they hire and who they want working and representing them through the organization. So it's very important, I think, the hiring process for me. I wanted to be part of that. The ongoing education, we have that offered to us all the time in different aspects and different things you can learn. The care plan, which Tracy had talked about, it's spelled out for us. Every morning before we head out, we read that care plan. It tells us exactly what it is we need to do and what our expectations are. It makes it much easier, being with the patient. There's no guessing involved. We feel very blessed when we're with patients, that we can bring our whole selves to the patient. Our mind, our body, our soul, because we encompass all of that with the team. It's a fascinating aspect of it, to have your RN and your social worker and your team manager and the CNAs, and there's so many of us all working for the same goal, that you feel like your whole mind, body, and soul is with you in doing that. The teamwork, you never feel alone. There's always someone there to answer that question, to help you through it, no matter what it is. There's a phone call or an email or in person. It just makes you feel stronger and more capable and to do your job. The support from everyone, wanting to listen and to help. The caseloads, they keep that at the perfect limit that allows you to do your day, spend the time with the patient, cover everything you need to do. You get those breaks. Occasionally, we get the lunch. You can always make time for the lunch if that's something you really want to accomplish in that day. but there's plenty of time to see all our patients with the caseload. And I know, some people will say to me when I'm in a facility, whether it's a caregiver or management, they always ask, what are you seeing when you enter into our facilities or into the homes that you notice? And from my perspective, I think I would just say, CNAs are busy. We have a lot to do. And because we spend so much time with the patient or the resident, we want to make everything just right for them. And we want to do everything we can do. So we are very busy. And I know we don't always have all the staff you may need, but I would go back then to investing in the training. With a Grace, they've invested so much time in training. We spend many, many weeks in training and orientation that by the time we hit the road running and, we get into the facilities, we're prepared. And everything we need is within us or a phone call or email away. So I think for me, most importantly, was that training aspect. I know what is expected of me, and I know I'm never alone out in the field or in the building. And I know talking with other CNAs in facilities or, homes, that's what they're looking for, is that comfort level knowing they're prepared for whatever comes their way and they're supported. No matter what, the support is always there.
Great. Well, thank you so much, Tracy and Sue, for sharing your story. We are now going to move on to Ryan Hansen from Pinecrest Nursing Home. And so we will pass the mic to Ryan.
All right, let's see here. Can everybody hear me? I'll look at the chat with all to see if anybody says no, I guess. Or maybe the host can tell me, because I see a lot of audio issues. Otherwise, I'll jump into it here. So we recently kind of revamped our orientation process, and we're actually going to continue to change it. If anything that changes, we're going to, evaluate and then re-implement. But the big change was us merging our new employee orientation with our continuing education for our current employees. And let me just check here. Good, perfect. And a couple of reasons there. One being that a lot of the materials that are being covered in orientation are the same materials that need to be covered as continuing education. You look at some of your things, your basic ones like resident rights, fire safety, infection control, HAZCOM, HIPAA compliance, and emergency preparedness. Those are all materials that all new employees should go through and that all current employees should be reviewing on an annual basis anyway, so we combine those. Now, the other benefit, the more benefit for the employees, is our new people get to meet some of our existing people and spend a couple of days with them. We currently have a 3-day orientation process. So when our new people are first going up to the floor, they're not going up and not knowing anybody besides the presenters who have given them orientation. They're going up to the floor and going to be working side by side with some of the people that they just went through these educations with. And some of that, as the slide here says, listening to them, some of these changes came directly from the evals that we've had from previous orientations. Newer employees saying, when I got to the floor, I didn't know anybody and I didn't really know who to go to. So that's what kind of led to the brainstorm of, hey, let's do them all at the same time. I think we're probably good for the next slide. So just to give you a little bit of information about Pinecrest, so we are county-owned, community-supported. So we are Lincoln County. We have a short-term rehab, which is 20 beds. We have we call it the special care unit. It's a dementia care unit, which is also 20 beds. We just recently opened a hospice end-of-life care unit, which is 11 beds. And then everything else that makes up the difference between that and the 180 is all of our long-term care, which, of course, as all of you would be aware, Long-term care then does have a mix of short-term people in there, dementia residents, hospice, palliative. So that's just kind of our catch-all for everyone else there. You can go ahead and move forward. So yeah, we held team meetings. One of the first things I did in my role as director here, which I've been in about a year now, was I sat down specifically with the nursing department, but then we kind of applied it to other departments as well. And I really basically said, we're in a position where I could hire every person that walks in the door, and we could fill staff. But do we want to fill staff, or do we want to find quality staff? And the resounding response is, yes, we want quality staff. We want to focus on recruitment, focus on retention, get staff in here that are going to stay, that are going to know what they're doing, as opposed to the revolving door that all of us have had at some point in time. And with that, of course, turning that background of employees and saying, that means until we find these good staff, we're going to be asking for people to pick up, and we're going to be looking at, using our casual pool more often. And again, they said we'd rather do the harder work now and work more now and get those quality people in than to just fill with bodies, so to speak. Go ahead to the next slide. That's repetitive, so we'll go ahead. Okay. So a while ago, they did we did away with mandating shifts. That was prior to me coming on. One time they did mandate, and what they found was that actually hurt overall attendance. People would, if I'm the AM shift person, and I know ahead of time that PMs is short, so there's a good chance they're going to mandate me to stay, well, I'm just going to call in for AMs. Not saying it's right, but it's what happened. And I can tell you from other facilities I've been at, mandation does generally not only lower morale, but I have seen that same pattern of people then calling in preemptively so they don't get mandated. Rather than mandated, we do offer bonus for any pickups. And then we do other things, just fun little things. Hot days, we'll put up lemonade and, of course, ice water as well. Severely cold days, hot chocolate type items. Bad weather days, so people don't have to worry about going out to get food on their lunch. We'll give them meals here. Also being flexible, some of the bad snow days we had up here and people called in, we would just say, we've had enough call-ins and we know that the weather's bad enough that, we're not going to count this against people's attendance. Now, they still had to use vacation time or whatever they wanted to use to try to make up those hours, should they so choose. But when you have half of your staff not come because of weather, it's not, people making it up. So being flexible with that as well. Recognizing efforts, allowing people to vent. We have an open door policy. Anybody can come up and speak with members of management. Now, of course, we have our own work to do too. And I tell people in orientation, we have an open door policy, but we also want to meet with people by appointment unless it's an emergency. And that's not because, I think you can have both those things at the same time. It's to say, I am definitely going to make time to meet with you and make sure I have the time to meet with you. So we just need to schedule a time to do so. And I'm very flexible with that. I'll come in early to meet with night shift staff as they're getting done with their shift. I've got a PM supervisor that's more than happy to meet with night shift staff right before the start of their shift, and otherwise everything else in between. We can make appointments during people's lunch hours. They can come before shifts if they're PM. They can come after their shift if they're AM. And allowing that flexibility and allowing that appointment time so this is their time is actually very beneficial. At least we have found it to be. Of course, when we're out on the floor, we do 90-minute rounding, and obviously that's primarily nursing, but other staff pitch in as well. Other staff will pop in and answer a call light, see what the person needs. Certainly, there are many things that only nursing can do, but I've answered call lights where somebody literally just can't reach the remote, or they would like their TV station, or something very simple that any staff member can do. And if a non-nursing staff member were to answer that call light and find that it is something that they cannot do, that they need a CNA for, they can at least let the resident know, okay, yep, I will go let a CNA know, and they will come get you, as soon as they can. And that way the resident has at least had contact with a staff member. So they know, hey, somebody's heard me. We leave the call light on because the need has not been met. And then that staff member would just mention to the nurse or the CNA, so and so, I checked on them. This is what they need. You can go on to the next slide there. And let's see here. I'm going to beep here. Okay, that's not for me. So we hire people that want to be a CNA. We hire into a hospitality aide position. So we have these, we have these exclusively on PMs. I did just recently hire one knock shift hospitality aide. I'll get into that in just a little bit. The hospitality aides are really there to help the CNAs, and they do a lot of tasks that are not CNA tasks because those are skilled, and since these people are not certified, they can't do them. But there are lots of things that our CNAs do that you don't necessarily need to have a certification for. Again, like I was just saying, for call lights, the hospitality aides can certainly answer call lights and respond to needs that are not CNA skilled tasks. They can certainly provide transportation to and from dining room therapy activities. They can pass the waters, they can pass the snacks, they can do some one-on-one interaction with residents. They just can't do direct resident care. So we just say, hands off. If it's not hands-on care, then we should be good. If it's hands-on care, you shouldn't be assisting or doing. We do, of course, hire them at a slightly lower wage as they don't have the certification. And then we do offer, if somebody is currently working at Pinecrest, we will offer to cover their class to go to get their CNA. And this is, so usually we would hire somebody in this hospitality aide role, have them work for a while, make sure that it's working well for them, working well for us. And then we work with NTC that they can sign up for the class, and NTC would reach out to us. They say, hey, so signed up for the class, and decided that you guys are going to pay for it, yes or no. And then I say, yes, sign off on it, and they go to the class. Then the hospitality aide that I hired on nights, I kind of created a position, finding that, a lot of the stuff that we were doing at nights, I'm sure a lot of you can attest, a lot of things kind of get put on the night staff because it's quote unquote slower, which it is. But, nights kind of sink or swim. It's slow and then it's not. And I'm sure anybody, here would agree with me. But during that kind of slower time, we had a lot of our staff doing the linens, passing incontinence products, doing things like that. But then what they were finding is they were so busy doing that one thing did pick up on knocks. They were then struggling to complete those tasks and the CNA tasks. So I said, well, these are all tasks that aren't skilled tasks. So I'm going to bring in a hospitality aide, and I'm going to have them do that and actually more. I created a full-time hospitality aide position that does the incontinence product pass, does linens. They also do the wheelchair washing. You don't need to be a CNA to wash a wheelchair. Wipe down lifts. They can make beds as long as they're an unoccupied bed change. So that, one person then takes on all those tasks that the CNAs were doing on NOCs and now don't have to. So we really use the hospitality aides as a CNA support, giving them more time to do their actual skilled tasks. I can go on to the next one. So retention. Right? So we want to do everything we can to retain the good employees that we have. A lot of the times we every year we have an employee recognition. We recognize how long people have been here, which is great, but you got to do the kind of daily things too. We do employee rounding. And when we first started going out, we'd have the department heads go out. We have this little form that we have questions on and we fill out. The problem is the staff saw department heads coming out with a clipboard and a pen and asking questions, and everybody just clammed up. Oh, everything's fine, everything's good, I'm going to run away now. So we kind of went to a little less formal process. I myself, anyway, I'll go out and do employee rounds, but I don't have the clipboard, I don't have the paper. I just go out and touch base with staff, one-on-one or in small groups, kind of seeing what's going on the floor, seeing what they think they need help with or what they might need more of. Those kind of conversations is really what led to the creation of the knock shift aide or hospitality aide position. Was just touching base with the knock shift and looking at the numbers and saying, we're looking at these numbers and ratio, staff to resident ratio for knocks. We're right on the money and where we should be. Why are we still struggling? And it's well, yeah, we're fine until 4 o'clock in the morning hits, and then all the call lights turn on, and we start our last rounds, and this and this and this, but we still have wheelchairs to wash, and we still have these other things to do. So those conversations and recognizing what the staff is doing and what their struggles are makes a big difference, in my opinion. And, that will hopefully help with the retention of the staff. Again, haven't only been in the position that I'm in right now for a year. I don't have any numbers to say that, oh, we were here and now we're here. But now is the time we're going to start really crunching those numbers and compare them to a year ago. All right. And then the one other thing is, if we do have somebody who's maybe hired into a position that isn't working great for them, but maybe a different position in the organization does, we will certainly look at making those transitions. We've had transitions of people that are in nursing who end up in dietary or housekeeping to dietary or any combination thereof. Just because one job position isn't good for a person doesn't mean another one might not be a good fit. So we're certainly willing to look at those as well. Going to the next one. Again, listening to what they have to say, I guess I kind of already touched on that. Let's see. One thing that we did change as far as scheduling goes, we did get our scheduler a specific work phone. And we talked to staff and found out what staff would be interested in receiving texts, and the majority of them said yes. So we have a work phone that we send the messages through for shift pickups, for availability. That's working really well. Staff seem to really like that. Let's see here. I can answer a question quick here. In terms of finding the right CNA, do you have a screening process do you use prior to an interview? What questions do you ask? So we use Indeed quite a bit for our hiring process. Just to answer part of that question quick. There's not a lot of pre-screening. I base a lot of my deciding, what's going to be a right fit or not on the actual interview. Obviously, because we have people that might be applying that don't even have a CNA. So there's only a few real basic questions that we're going to ask on Indeed, and then we bring them in. We're working on formalizing some of our questions as far as interview questions. But, some of the stuff that I might look for is, how many jobs has this person had in the last year? And not to say that, they've had 4 jobs, they're going to be bad, quote unquote, but it's certainly something to ask about. Because I've had people that, I moved up here a year ago and I just haven't found the right fit yet. I'm not an expert on that topic by any means, but that's what I do personally is look at that resume, look at that work experience, see if there's any kind of red flags. If there's not red flags, I'm a pretty big believer in giving people a chance. So that doesn't really answer that question great, I guess, but it's kind of what I have. Let's see here. And then the flexibility, I think, is a big one that we really push here. Obviously, somebody gets hired on, we're going to hire them into an FTE, and they're going to be set a certain amount of hours. But we try to, as much as possible, work with staff around school schedules, around childcare, around school schedules as far as their children going to school. We have a lot of people, that's what they base their position off of is, well, I'm going to work AMs because my wife works PMs, and then we've got coverage for the kids. And so, if we can be flexible with them, they are far more flexible with us. If we can give somebody every Wednesday off because they need it off to pick up their kid because that's the one day they don't have rides arranged for, they're going to be much more likely to pick up on a day that we need them. So what we do ask, though, for somebody that has a recurring time off is we do ask for a start date, an end date, obviously what days or day that they need, and then just a reason. And not that we need to have them explain themselves or justify themselves, just for the fact that we may need to prioritize to a certain degree. If we have, multiple people asking off for a recurring day off and one of them is for childcare and one of them is because I've got swimming lessons, but we're probably going to talk to the person with swimming lessons and say, is there any way we could rearrange? And people are very, very happy to do that. So they'll put on there, this semester I've got classes at this time on Friday, so I can't work this shift on Friday. But my semester is done on this date, so it's only from this date to this date that I need it, and then we can look at it again. and people are really happy to see us, really trying to work around their work-life balance. I can go on to the next one. Let's see here. Employee rounding, I already talked about. Onboarding process, I already talked about. Like I said, I will talk about, we've been doing it for a couple of months now, the way we're doing it. But like I said, we are looking at some additional changes. There's some additional restructuring or reorganizing that I would like to do. I think we can streamline it a little bit more. But one thing that I really like that we're doing is we're going through the mission, vision, values, going right in the employee handbook. We give up the employee handbook, put it up on the big screen, and talk about mission, vision, values. Let's see here. Yeah, and again, bringing the new team members and the current team members together to form that work relationship, friendship, bonds, so they've got somebody to go to talk to once they're up on the floor. All right, we can go ahead. Again, no shame in letting and admitting something didn't work, so to speak. What we're doing right now, I think, is better than what we were doing previously, orientation-wise, but we're still already looking at ways to change it. One thing, after our first go-around with this new system, right away everyone was like, oh, we should change this, and we can change this, and I said, no, we're going to do this a couple of times the way we designed it, and then we'll make changes. And I'm all about, looking at something and changing it, but you're not going to tell from one time around what should or shouldn't be changed. Now that we've done it a couple of months, we can really say, yes, this is working well. No, this isn't working well. I need more time here. I need less time here. The other thing that I'll put out there, we actually increased our orientations to every other week. And the reason, we can kind of do that, the first time I brought it up, the concern was brought up of, well, what happens if we don't have any new hires? And then we're going to have all this orientations planned, and there's not going to be any new hires. And I said, well, that won't matter. We'll still run it anyway, because we're still going to have about 10 or so of our current employees in there either way. So there's another advantage of combining the two, because I'm sure other people can attest here. How many people on here have had their orientation, say, once a month, and you have an interview come in on orientation week, and they're fantastic, and you'd love to offer them a job, but then when you say, but we don't have another orientation for 30 days, they go, oh, well, if I'm still looking by then, maybe. So I run into that many times, more times than I can probably remember. So I really pushed for that, because now, even if somebody comes to and interviews with me during orientation, I can still say, hey, great, we can hire you and bring you on in 2 weeks. Most people are probably going to have to give a 2-week notice at their job. And even if there's somebody who's currently unemployed, waiting 2 weeks to come in is way better than waiting 30 days. And I'm not sure how many slides I have left. Let's see what the next one says.
Sharing your story with us. And now, if you'll be patient with me, I am going to switch to Laurie's slides and let her tell her story. All right, go ahead, Laurie.
Am I on?
You are, thank you.
Great, I wasn't sure. I'm not very good with all this technology stuff. So, hello everyone, my name's Laurie Carroll, nursing instructor at the Wisconsin Veterans Home in Union Grove. And we have 158 skilled nursing facility beds and 40 assisted living CBRS beds. And we started a program that we're having, the same issues as everyone else, trying to get enough help and everything. So we were trying to find a way to sort of help our CNAs with some of the things that you don't necessarily have to be certified for. And sort of, like what Ryan was talking about with his department. And we call ours therapeutic member assistants. And, they're non-certified individuals in delivery of non-hands-on services. So we have them doing a lot of different things that, that you don't necessarily have to be certified. Some of the activities, we have them cleaning residents' rooms, helping us clean up after the dining areas, after meals, activity areas, getting people ready for the bingo and just bringing them to the places where we're having the bingo or music, a lot of music programs we have. And instead of the CNA having to go off the floor and taking the member to this and then coming back and getting them, we can have these therapeutic member assistants do all this. The common unit areas, we have them picking up and keeping track of members, sort of keeping them busy, especially if, oh, I'm sorry, if you could change the slide there, Diane. And for, especially with, no, I'm sorry, I lost my train of thought. Common unit areas, you know, especially after meals, because it seems like after meals everybody wants to go to bed right away. So if we have some of them, you know, sort of in the area and keeping the members busy and entertained, they don't always want to, you know, get to their room right away and have everybody's lights on at the same time. So let's see, the next slide here. I don't know if they can hear me.
Indirect patient care.
I'm sorry, I can't hear you.
I have the slide up, indirect patient care. Is that where you would like us to be?
Okay, I'll go from there. It's just not up on my computer at all. I still have the one that says non-certified individuals. But I'll just go from there then. So indirect patient care?
Indirect patient care.
Okay, we'll go from there. So member inventory, you know, when people come in on admissions, we'll have them count, you know, their possessions that they bring in, their clothing, any other supplies that they might have. You know, that saves a lot for the CNAs to be doing. Supply inventory, we have them stocking our rooms. You know, just if they would need lotions and briefs and stuff like that, we could get the therapeutic member assistants to help us do all those things. Passing of the clean linen, cleaning of members' rooms, their bedside stands, closets, etc., helping them put away their laundry, making the unoccupied beds. When we're getting new admissions, we can have them making the beds for them and trying to get everything set up for a new admission to come in. We can go on to the next slide, would be the housekeeping tasks. We have them performing, we can have them clean the tubs and sanitize them with the showers. I'm sorry, I just keep hearing beeping. I'm not sure if I'm here or not. I'll just keep talking. Cleaning and sanitizing tubs, I said that. Trash removal, I mean, that can take up a lot of time out of the CNA's routine, you know, having to empty all the trash and everything in the rooms. So we have them doing that. Disinfecting the handrails, doorknobs, nurses station, that's a big thing for infection control, especially like on our memory care units. A lot of people, the members, you know, don't always know to be washing their hands. So definitely I teach them with orientation and that to really concentrate on infection control, making sure the members' hands are washed, you know, before and after meals for sure, and then even periodically during the day just to remember, you know, to wash their hands. And especially if we have some kind of an outbreak, if it's, you know, something that's contact, we can get them to wash those handrails and that more frequently than our housekeeping staff can do. Cleaning the refrigerators, so some of our members have refrigerators in their rooms and it is their responsibility to keep them clean, but sometimes that doesn't always happen. So our therapeutic member assistants can go through and help clean their refrigerators. Cleaning of the dining rooms, like I said, we have housekeeping staff, but you know, things happen in between when the housekeepers come and that really, they can help us assist with that. Cleaning of all of our equipment, mechanical lifts and the wheelchairs, that's a really big help for the CNAs. The next slide would be the therapeutic well-being. Deliver mail to the members and assist them with opening it if appropriate. That's a big help. I know a lot of members, they can't always get their mail open, and just reading to them and that is just something really nice that they can do for them that sometimes the CNAs are just really busy and don't always have the chance to do. assist with activities, and our sensory room that we have for the memory care unit, unit activity and individual visits activities, especially if we know someone, maybe there's someone just having a really bad day and they just want someone to sit with them and hold their hand and talk to them. We can have them do that. Music and memory, we have the program with the iPods and everything that the therapeutic member assistants will assist the members to have the put on so they can listen to their music. TVs and radios, we always have the music going in the dining rooms when there's not meals to keep the members engaged with music. Bulletin board displays, what the things that are going on in the facility, they can help change the different displays that we have on there. Transportation and pushing wheelchairs. We have a lot of activities, and we have a very big building, and it's quite a lot of distance between sometimes one of our Gates Hall all the way over to Bullen. So it's quite a different distance for people to be walking or even to wheel themselves. So having them help us transport people is an extremely big help with that. So the next slide here with, like I said, the title is Therapeutic Member Assistants. We have 8 of them. They're LTEs, which is a limited time employee. So we have 4 of them working from 8 a.m. to 1 p.m., and then 4 of them working 1:30 to 6:30. The first 4 we hired in January, and we have 6, and we are talking about hiring more, and we're sort of talking maybe even on night shift because, again, we have a lot of things probably they could do at night to help us out with, like washing the wheelchairs would be a big help. And just even sometimes, you know, if somebody can't sleep and they just want somebody in the room with them, that would be great. And the next slide, lessons learned. We do have them all over different units. We try to keep them assigned to specific units, but sometimes, you know, if something's going on a different one, we'll put them somewhere else. And I'm not sure about the pagers. We're still working on a system to keep them, you know, track where they are. And then there's a problem too sometimes that a lot of different people want to tell the TMAs what to do for the day, and we kind of have to curtail it a little bit and say, no, you know, we'll have the nursing supervisors let you know what we want them to do. Of course, you know, they can give them suggestions if they need help anywhere on a certain time. We also have trained them to be CBRF certified. They can, with the first aid and the fire safety and the standard precautions, but we wouldn't have them, of course, passing medications. But it helps us over there at the CBRF building also, and because usually we do have CNAs over there, so they can help out. A lot of members over there are self-sufficient, but even every once in a while, you know, they just like to have someone over there to talk with and, you know, just companionship in that. So some of our future goals, we're having them set up, I know the next slide, Diane, setting up our daily Foley care kits, isolation carts, and then we're working on getting them in the feeding assistant training program. So that's just a few things, and I think the program is really going pretty well. I've been hearing, at first it was kind of, you know, the people weren't too sure about it and they weren't sure what they were going to do with, but I think as we've gotten more people in that, it's going along a lot better, and people are becoming more appreciative of our therapeutic members assistants. And that's all I have, I think.
And thank you to all of our speakers for sharing their information. And we do have some time for questions. And since we have a little bit different system than we're used to, Lydia is going to come back on and explain the options for submitting questions.
All right, thank you, Diane. So as Diane said, if you have any questions, please use the chat function and send the questions to everyone. We will then go through the list and get through as many questions as possible. If you would like to ask your question out loud, please just leave a chat noting this, and when we get to you, we will unmute your mic for you so you can ask that question. At this time, I'm going to unmute all the speakers so that during this Q&A portion, they can respond to your questions as they need. right, Ryan and Laurie, you are unmuted now. The first question was at the beginning from Norma. How many weeks do they spend in orientation? And I'm assuming this question is for Grace because this question was submitted during your presentation.
Our CNAs spend at least 3 weeks in orientation. A small portion of that is in the classroom, and then they are actually with an educated preceptor. We do have special preceptors for all of our different disciplines out in the field. And then together they meet with their manager to make sure that the new employee has demonstrated their competencies and that they're confident in being able to do the things that are expected of them. And the CNA preceptor provides input to the manager about the new employee having finished that process.
All right, the second question was also for Grace from Tony. What are some strategies you use to provide emotional support to your employees?
So we have some different ways that we do that in light of our provision of end-of-life care. At least monthly, our teams that are organized together in a specific geography, serving probably anywhere from 70 to 140 patients, they go through and have a memorial service that is put on by our spiritual grief counselor. So they revisit all of the patients that have died while on service with us. And then they usually do something uplifting, inspirational, if you will, to help staff. They have an opportunity to talk about the patients that they cared for and how they're feeling or what they might need. We also put in place a situation. Anybody can let us know if they feel like we're caring for someone currently that has been very challenging and we need some time to talk about that. An example, as we care for pediatric patients, we'll bring members from the American Family Children's Hospital. They'll come over to a Grace, and the members of the team that are providing direct care to that child will talk through together how it's going, what are the goals that we're trying to meet for that patient and family, and work on that together. And or afterwards, we will have a debriefing to learn from and to see if we should do anything differently if we would encounter that same patient care situation in the future. Our supervisors have open door policies. They very much encourage the team to call one another or bring the team together to talk about what's going on in their daily work. And we also have EAP as a benefit for all of our employees.
All right, the third question, does anyone have a staff retention budget? If so, how much? The second part of this question is, what is your process and what benefits or negatives do you experience?
Since no one's answering, this is Tracy. We did, and this was quite a few years ago, when we went through a period of shorter staff, we did do a retention bonus at the time to have the staff recognize that we appreciated everyone that was hanging in there during that very challenging time for our teams, and it really did help. And as I said, we did that once, but it was in light of the situation, so.
All right, and then the second to final question, how have you communicated with residents and families that these individuals cannot provide direct care?
So I can speak on that for the hospitality aides. We do a lot of just one-on-one education with admissions is the first place we would hit on that, of explaining what the different roles are and what they can and can't do. You could really ask the same question for somebody who's not well versed in medical facilities. Well, what's the real difference between what a CNA and a nurse could do? So we really tackle that on admission and then kind of as needed if or when questions were to come up in the future. But anybody that comes in would know what the nurse can and can't do, what the CNA can and can't doing with the hospitality aide. Or really, we don't even specify that as much as what nursing and non-nursing can do, and then explaining, that a hospitality aide is not a certified CNA. And that seems to work pretty well. We don't really have concerns from families or residents that come up of why didn't this person do this or that. So that's how we tackle it.
We've spoken to
No, go ahead, Laurie.
We've spoken to the families and the residents through like our member council meetings and that, and explained what these new positions were entitled, what they were doing, that they couldn't do the direct care, but they could assist with other things and that, and it all seems to be, positive.
All right, and then the final question is, are the aides dressed in different color scrubs to indicate their position is different from the CNAs?
So we're talking the hospitality aides again? No, not with us. If I had my way, all the positions would be color coordinated, but that's just me. And coming from just being a male nurse, I can't tell you how many times in my career I've been doctored. So I would love to see coordination. And it actually really helps. I've been in facilities that do the color coordination, and it really, really helps in any kind of investigations or any kind of really anything. Because often, if you're not a doctor, you're a nurse or a CNA. So I've had situations where it ends up, it was actually a housekeeper, but our housekeepers were scrubs too. So if someone were able to say, well, it was somebody in blue scrubs, and I can say, okay, well, all of my nurses wear blue scrubs, then that helps me quite a bit. So I would like to see that, but we don't have it.
And we don't either. We don't have any other different color scrubs either for our therapeutic member assistants. We just go with their name tags. They have their name tags on, and they're pretty good size, and they have their position and everything. So no different color scrub for us either.
All right, that was the final question for today's webinar. I am sending an evaluation link in the chat right now. You will also receive an email following up with that link as well. I want to say thank you to our speakers, and I appreciate everyone being patient during our technical difficulties today. I hope you were able to still gain a lot from this webinar.
Thanks, everybody, for attending.
Thanks for having us.